We seem to have resolved the technical difficulties.
Thank you for your patience for those online. And if you could let us know if you can hear us, that would be great.
I can hear you.
We can hear you.
Great. And people in the room should have no trouble hearing us. I
Mark,
took the liberty of cracking a few windows. So I'll let people in the room decide how the climate control is going. It seemed a little warm. And so now we have a little ventilation, but feel free to be autonomous. I guess we go through introductions, sort of a final set of introductions. In case you think you're in the wrong room, this is the Mental Health Integration Council. And Mark Levine and Allison Crump, we are the co-chairs. This is our final meeting. Very exciting. We'll go around the room real quick, just sort of in order, starting with Kathy.
I'm Becky Henson, Director of Health and Healthcare Integration for the Department of Mental Health. Hi, everyone. I'm Pat Jones. I'm the Interim Director of Healthcare Reform and Community Services.
Good morning, I am Kay Van Woolley, Director of Trauma Prevention and Resilience Development for the state of Vermont.
I'm Nicholas Nicolay with Washington Mental Health.
If you could make sure to speak up for folks who are not in the room.
Hi, I'm Leslie Nelson. I'm the coordinator of peer support and the coordinator of the collaborative network approach at Howard Center. I haven't been to many of these meetings, but I am happy to be here today.
I'm Cindy Taylor Patch. I'm the CCBHC project director for Rutland Mental Health.
Ann Donahue, psych survivor.
Laura Lightford with PMH, just providing some administrative support.
Morning, I'm Laura Holman. I'm Director of Child and Adolescent Family Unit at the Department of Mental Health.
Haley McGowan, Children's Medical Director of the Department of Mental Health.
Logan Haig, I'm a psychologist at UT.
Mary Kate Loman, Director of Vermont Public Policy, Vice State Premier for their system.
Hi, everybody, Josiah Mueller, Director of Value-Based Care at Home Care Vermont.
Anna Van Fleet, Director of Grades and Forms for Life and Contact Bar.
Samantha Marie Blanco, Assistant General Counsel, focusing on health insurance regulation at DFI.
George Karakakis, CEO of HCRS, we're the designated community mental health agency serving Wyndham County.
I'm Samantha Sweet, Director of Mental Health Services at DMH.
Morning, I'm Jeffrey Temperature, Heehan, Director of Policy and Planning for the Department of Children and Families.
Morning, I'm Steve DeVoe, IT and Pronouns. I'm the Director of Quality and Accountability at the Department.
Morning, Cheryl Wilcox, Chief of Pronouns. I'm the Director of Mental Health Collaboration with the Department of Mental Health.
I'm Andrea Wicker, Program Director of Vermont Retain.
And I'm Karen Hike, the Medical Director for Vermont Retain through the Vermont Department of Labor.
A little hard online, but let's let people online introduce themselves.
Let's see, and we'll ask them to pass it.
Yeah, we'll start with Walt because I can see him on the screen, and if you could then pass it to whoever you see next.
Okay, Walt Wade, Executive Director, Vermont Psychiatric Survivors. And I see Mike.
Good morning, Mike Fisher, Healthcare Advocate. Sandy?
Good morning, I'm Sandy Yando, the Executive Director of the Vermont Federation of Families, Children's Mental Health. Laura, do I see you over there?
Am I the Laura that's logged in?
She's introduced herself already.
I can jump in. My name is Nicole Rao Midiki, pronoun she, her. I work at the Department of Health in the Division of Substance Use Programs, and in my role, I help to oversee recovery services in our 12 recovery centers throughout the state. And I will turn it over to Devin.
Hi, Devin Green, Vermont Association of Hospitals and Health Systems, she, her. And I'll turn it over to Simone.
Hi, Simone Rischemeyer, Executive Director of Vermont Care Network with Vermont Care Partners. And I'll turn it over to Julie Tesler.
Good morning, Julie Tesler, she, her pronouns, Executive Director of Vermont Council and of Vermont Care Partners. And I'm sorry, my camera is not working again today on Teams. So I think I see Wendy. I'm not sure.
My name is Wendy Trafton. I work in the Office of Healthcare Reform at the Agency of Human Services. And I'll turn it over to Megan Mitchell.
Good morning, Megan Mitchell, and I'm the Director for Clinical Services for the Vermont Department of Health Division of Substance Use Programs. And I will turn it over to
I can jump in. This is Julie Parker, Assistant Director of the Blueprint, Assistant Director for the Blueprint for Health and the Agency of Human Services. Hi, everyone. I'll turn it over to Tony Folland.
Hi, Tony Folland, Division of Substance Use Services, and I will pass it over to Simone.
I already introduced myself, but thank you.
I missed that.
No, all good. I'm trying to see. I'm looking at the list. Is there anyone who hasn't gone?
Awesome. Thank you all. That was very organized and efficient. We have a few introductory remarks to give, but we have an unanticipated few sentences of introductory remarks we thought should go ahead of our remarks because these are so powerful and I think set a tone for us as we move forward in Vermont on mental health integration.
So I was doing some research on something totally different and stumbled across this statement. Since popular prejudice against asylums and superstitious views of insanity have been relegated to the past, and insanity has come to be recognized as much a physical disease as, and it goes on to reference medical conditions, says necessarily follows that friends and associates will demand the very best treatment that the state can provide. Date 1898, biennial report to the legislature.
Thank you so much.
Cutting edge, Ann.
Yeah.
Yes. And we still require legislative reports to this day.
Obviously needed.
So we've been doing this for short of a couple of years. And even during rougher times in Vermont, have tried to keep an every other month cadence. I've had 4 work groups going. They have had their own cadence and times for coming together. Some of them preordained, some of them ad lib, if you will. And I think most of us would agree the process hasn't always been as straightforward as one would think. We could start here and end here, and we have solved the problem. We've asked a lot of each one of us, and we've basically been through, I think, some fantastic discussions, some presentations. I think we've come full circle sometimes and not understanding one concept and fleshing it out a little better and getting a little more comfortable with it. And we've addressed a lot of topics, some of which weren't as comfortable as the others. And some may feel we did a lot of talking and what else have we done? But that will change. I think just based on the tone of the room, there's been a lot of relationship building, which is key. Coming from the public health world, we accomplish nothing by ourselves if we don't have partnerships and collaborations and work across not only the Agency of Human Services, but across all sectors in government and society. We go nowhere because we cannot possibly move the needle on public health writ large just by saying this is our job and we do it. So we've had a lot of good discussions on the integration of care, on how to build a unified system. I think we've seen concepts come that we weren't even like having on our radar screen, like perhaps peers in primary care practice. And many of us have shifted our positions on that, just not understanding what the role was initially and trying to understand better and coming to a different place, which couldn't happen in one meeting or in 1 hour, certainly happened over the course of several and some small group discussions. The words whole person approach are so obvious now. They may not have been part of the lexicon for everybody when we began. Actually putting an individual's goals for themselves first, even though here we're talking about trying to create a whole system. And then the word equity, of course, comes up. It's sort of a catchword now that sort of comes up too often sometimes, and I don't think everyone appreciates the depth of what it means when it comes up in different settings. But I think in this setting, and as we've deliberated, I think an appreciation for equity being one of our defining principles has really resonated well with everyone. Some of you have actually said, we don't want this to end. Not that we love meetings, but we think we can continue to do this. And actually, Kathy has rather artfully read the crystal ball about the future and said, well, we actually officially may end today, but we don't actually have to end the work of interpersonal relationship building and strategizing that sometimes getting groups of people together can help. And in that way, I think we've really modeled what integration is supposed to be like. A diversity of voices have been heard. We've sort of tried to take into account what's been said, taken time for discussion, learned about different aspects of people's work that we may not have been as familiar with in the first place. So let's just take a step back and see what brought us together in the first place, which was our legislative charge, which has 5 components to it, if you will. And in the left-hand blue side mentions the words principles for mental health integration. Though they're not as well defined on this part of the excerpt, if you will. So number 1, identifying obstacles to the full integration of mental health into a holistic healthcare system and identifying means of overcoming those barriers. I think we agreed early on that some of the obstacles were a lack of relationships across professions, across practices, providers, a lack of understanding of what everyone did in their own role description, a lack of agreement about what does the term integration mean, and a need to build some consensus around that. Is it co-location of medical and mental health providers? Is it a series of MOUs between mental health and medical practices? Is it one location where Vermonters can go and get the assistance services and care that they want? So we did set about building these relationships and that understanding. We've had a lot of guests who presented quite a number now of specific integration models. And as I mentioned earlier, we learned what the terms peer support are supposed to mean. We talked about what federally qualified health centers do, what the Blueprint for Health does, the hub and spoke, medication for opioid use disorder system of care, the expansion of that model to involve mental health treatment services and expand its scope of substances that it addresses. Speaking of the principles, in the document that we sent off to the legislature for the first report, we mentioned that our principles for integrated whole health care would be care that's equitable, patient-driven, based on appropriate and sustainable reimbursement for providers that allows for ease of providing care based on evidence-based emerging practices, regardless of the insurance that the individual may have. And that's built on a robust IT system. Looking at number 2, helping to ensure the implementation of existing law to establish full integration within each member of the council's area of expertise. We've had a huge number, variety, and overlapping nature of the integration models that have been presented. We agreed that the principles we just talked about should guide our integration efforts and try to bring things together in that way. I think learning relatively early in the game that we were not going to be able to just pick a model and say, all our money goes in this bucket and we don't have to work any further at this point in time. We also agreed that whole health support is necessary. And I won't go into great details again about the definition of whole health, which is well stated on this slide. But it has so many aspects to it. It sort of buys into the World Health Organization, 75-year-old definition of health, and just expands it with the term whole health. It implies you don't look for the absence of disease or infirmity, but you look for the presence of well-being. And then there's a whole bunch of components: interprofessional, team-based, longitudinal relationships, resilience, aligning, again, in that peer support way with the person's own life mission, aspiration, and purpose. Nirvana. Moving on to number 3, establishing commitments from non-state entities to adopt practices and implementation tools that further integration. Have we done that? Have we established those commitments? Perhaps not specifically, but we've heard from a lot of entities that I would call non-state entities. A fair amount from the Veterans Administration, fair amount from the University of Vermont Health Network, and the way those two non-state entities are on their own integrating care using some of the models we just talked about. We've heard kind of within state government from the Blueprint for Health. We've heard about the expansion of the hub and spoke model to include mental health. Looking at number 4, proposing legislation where current statute is either inadequate to achieve full integration or where it creates barriers to achieving the principles of integration. And I'll just quickly read number 5 because it's sort of just the catch-all of fulfilling other duties the council deems necessary to achieve its objectives. So looking at number 4, here, excerpted aspects of the statute, I guess we call it, statute. Here, the emphasis is on coverage. There's also a notation standard of care in the state. But there's many more words I'm just not highlighting for you that you can read on there. Then, of course, the all-important word access, but not just access, equal access. So getting again at opportunity, the opportunity to have true equity in an integrated holistic system. I think we've addressed that significantly and will continue to. Here, the statute actually talks about some principles and again, focuses on sustainability, focuses on funding. And of course, when you focus on funding, that brings a whole bunch of other things to the table. But the highlighted part of this slide and is a sort of teaser because of our guests who are here today, mentions the three words healthcare reform, which is a critical tie-in, which every step of the way we've said, we can do what we want here and have the visions that we want, but if this isn't tied in with healthcare reform, and if we don't have a sustainable funding system, then if we can't address all of those barriers that practitioners have talked about forever and ever, we've done nothing. This slide also talks about a critical alignment of mental health, substance use disorder, and physical health. Finally, again, the linkage with healthcare reform comes through in this part of the principles. And then access, affordability, quality are all very much integral to the vision that the statute had and that we are trying to follow through on. So my last comment will just, since DFR is in the room, there is a very important relationship there, as we know. And there's sort of common elements underlying the selection of these primary mental health and substance abuse services, which have to include the most common or routine mental health and substance use disorder services, outpatient and office mental health and substance use services, and services provided to all persons regardless of age or gender. I'm going to segue to my colleague, Allison, and move to the next slide.
So I'm hoping that as you read through those statutes that I think we all agree that there is some significant legislation already in place. And I think I would surmise to say we've learned that there are pockets of efforts happening and some larger movements happening. But one of our charges is to determine where and why it isn't happening. And is there anything else necessary, both through legislation or simply by coming together that we can do to move that forward? And so I want to highlight that there was the work of the council, and then we had some subcommittees. And so we had our 4 work groups that met through these 2 years, and they were focused on primary care, pediatric care, integrated funding, and also workforce development, which I know it was hard to have all of these conversations about all the innovative work we wanted to do while people were looking around and facing a staffing crisis. But I do want to highlight workforce development in our world is not about just getting more people. It's understanding the types of people you need and the places they need to sit in order to do integrated care. And so the recommendations that we presented in our report came out of these work groups and were informed by then consultation from the whole council. And that is the process that we'll be going through again. We had our interim report and we'll be moving towards our full report. And so just some highlights in terms of the principles that we laid out in the interim report that laid out some clear but also challenging next steps. One was providing recovery coaches and a support person such as a peer or community health worker to every person seeking care or services, which is a big goal. Another is basing services in a trauma responsive and equitable system of care. And that's one of the things we'll be talking about with Kaya here today. Another is incentivizing integration in pediatric care. And that's by providing resources such as financial support and implementation assistance. I think when we look around, there's a lot of people who want to do integrated care. There's a lot of barriers to get there. And right now, from what I've seen in the conversations, people are striving just to get sufficient care. And that alone is hard enough. So how do we incent and knock down the barriers to be able to elevate that? And then additionally, formally assessing the current state of parity in Vermont. I think that's a tall order. Parity is, the word is thrown around, you see it in the statute, but what does that actually mean? I know DFR is doing some technical work on, equitable rates, but there's a lot more to it than just that. And so how do we build on that work? And then aligning the workforce development goals with the Governor's Health Equity Advisory Commission. So when we're thinking about why and how persons who are dealing with mental health challenges don't get equal access or may not be treated equally or may come with an extra level of stigma or bias, how can we fit that into this larger conversation about equity and bias so that we're utilizing and leveraging that work, but also recognizing there's distinctions about mental illness and bias against mental illness that we want to pay attention to. And then lastly, looking for opportunities. I feel like whenever I say this term, it's like a bad word, but for sharing staff, because I think that's A, so much easier than done, and B, starts to get into a bit of turf war that I'd like to think this group has done a really good job of breaking down that turf and just trying to think innovatively about a world where you don't have enough people to do the work. Who do you really need in those seats and how much of their time do you need them for your organization? And I'll use the CPAP program, the Vermont CPAP program as an example. Everybody needs access to child psychiatry. Does everybody need a human being in their practice? And if we don't have those human beings, how can we still get what we need? And that seems to me as an example of people thinking innovatively of how you access that consultation and share that resource. And the workforce development group will be thinking and making some recommendations about more work like that. And so here we are, our final and last Mental Health Integration Council meeting, which means we'll be submitting a final report. And if you've been in the work groups or if you've been in this council and you haven't been able to be in every single meeting, it may be a little bit nerve-wracking to think about us wrapping this up in a bow as if we've got these, comprehensive time going to reflect that this is complex and challenging, but put forward a few steps. But that will be compiled and written and submitted to the legislature in January. So the idea is, just as we did with the interim report, we'll be sending that around for your input. I know that's overwhelming when you get those and you get this giant document. I will give, and we'll be talking about Kathy's great work in a moment, but a lot of this has been an attempt to take what we think you've said and put it on paper. So what we really want you to have an eye for is if when we put that on paper and you read that again and you're thinking, wait a second, that actually doesn't reflect, or now that I'm seeing it, that's not the way I would say it. That's really the feedback that we want. And to make sure that in some ways, what we write down, you're also committing yourselves to. So have that in mind. This is your thoughts put on paper, and we want to make sure that it's reflected back appropriately. When we take time in our small groups later, we'll be asking for your thoughts on some of these interim recommendations. So we've always tried to use this time as working sessions because we know once you leave here, it's hard to get your attention back. So there'll be opportunity today to look at that. And then in the coming months, we'll be sending out notices that will try to highlight your attention. Here's your last chance to really get your feedback and suggestions. I do want to take a moment, as Dr. Levine and I have been doing this, gosh, for 2 years. There wouldn't be an integration council like this without Kathy Hensey. And know you've gotten used to her name in your inbox. She has put a tremendous amount of thought and effort into this. Yes, she is the reason why it's 4 hours. But yes, the reason why it's 4 hours is she said to us from the very beginning, no one has time to think. These are really big issues. They are really complex issues. And I want to give people the time to come in here, think, discuss, meet each other, build relationships, and think again. And it was her vision that said, we will not do death by PowerPoint. We will not tell people what the plan is. We're going to make them anxious by being clear that we don't have a plan. You need to help us create the plan and to sit in that space together. And so Kathy will be retiring soon, and we are all very happy for her, but it's going to be a great loss for this work. And I'm just speaking for myself, that she's just been such an incredible thought partner for this. We're so grateful for all your preparation. And her wonderful supervisor, Cheryl, has put a little thing in the back there that has some creative ways to celebrate Kathy. If you're somebody who, you know, can look back on this experience and recognize the kind of space she set for you to do this work, I would encourage you to give a note to her. There's some fun stickers, markers. If you fill out a little note, Cheryl's going to create a scrapbook for Kathy. As this is one of many of her big efforts, she was also part of Vision 2030. And in that work as well, she took all the stuff we tossed up into the ether and put it down on paper in an actual beautiful format. So thank you again to Kathy. Okay, so before we break into small groups, we do have some guests here, and we wanted to talk to Pat Jones, the interim director of Healthcare Reform, and Kaya Ganguly, director of Trauma Prevention and Resilience Development. As when we think about the work we're about to do, and when you go into your work groups, these are some big giant umbrella efforts that we need to be thinking about how our work fits into. So we'll be doing a little panel interview now, and then we'll break out. But I know we only have you till 10:15, correct? Okay. Yeah.
Do we stay where we are?
I'm a little concerned about people online being able to hear Thea and Pat. I wonder, could we bring the table up there and put the laptop in the middle of all of it? That might.
Yeah, let's do that.
It'll take that a little bit better.
We don't really need the slides again, right?
We have the so.
This. And we got an email that said at 9:15, there's going to be a generator test or something, and the lights may flicker, the power may, who knows what, so we will go with the flow.
As long as it's not a spring test.
Well, it didn't say that. Who knows when you mess with power? Okay. Great to see these colleagues once again. Some of you may recall when Ina Backus was in Pat's position, we had some similar things to go over. Seems like that was forever ago.
Seems that way for me
Yeah.
too.
And healthcare reform marches forward, as we know. It's an ever-evolving picture, and as I emphasized in my part of the presentation, it's so critical to whatever we're going to accomplish. So let's start with Pat in a very general way, because you have your own visions and you have your own now notion of what is healthcare reform, and why should Vermonters care? What does it mean to the average Vermonter? So we could just sort of begin in a very general way that isn't necessarily mental health linked, but could be.
Sure. I just want to say thanks for letting me come today. I'm seeing a lot of people that I've been kicking around for a while, shall we say. And I see a lot of folks that I've worked with, worked next to, collaborated with over the years. There's some new faces. Heard just about everyone's name though. So it's just really nice, nice to be here. When I think about healthcare reform, I sort of try to keep it simple in concept anyway, because it's a really complicated thing. I think about how can we use public policy to improve healthcare and to address challenges that we see in healthcare. And this isn't going to be news to anyone in this room, but there are a lot of challenges in healthcare, and I'll just tick off a few that come to the front of mind. Affordability, quality, how to integrate care and services so that healthcare doesn't seem fragmented to the people who are receiving it. And that's obviously a big subject for this group. Workforce, do we have an adequate supply of people who want to provide care and services? Do people have access to healthcare? Do they have access to coverage for healthcare? Access to health insurance? How do we sustain the system in the face of multiple and sometimes competing pressures? So there are a lot of challenges to be faced. And, you know, in Vermont, we have a history of really trying to face them together. And so, again, when I think about healthcare reform, it's how do we use the tools that we have in the form of public policy to address those challenges and to make things better for the people of Vermont. We, in Vermont and nationally, the Institute for Healthcare Improvement, I don't even know when, maybe you can help me, Dr. Levine, but probably 20 years ago, outlined the triple aim for healthcare. And we have really used that as a North Star and as a guiding principle in all our work. It's, again, elegantly stated, simple, but really, you know, full of complexity when you think about how to do it. And so the triple aim really speaks to reducing growth in healthcare costs. And that's the affordability piece. It speaks to improving the quality of care and the experience of care that individuals experience when they seek healthcare. And the third aim is to improve the health of the population, so that population health focus. And there's a fourth aim that folks have added to the triple aim as well, and it's improving the experience and work life for the people who are providing services. And given the workforce challenges that we're looking at across the continuum of care, that seems like a particularly salient aim as well. So, you know, that's really been Vermont about healthcare reform. It's a national framework as well, so you'll hear other people talk about it as well. But that's both the simple concept and the very complex work that we've tried to do together with all of you and many others for a good number of years here now in Vermont.
I think that's a great description. I always feel challenged because understandably, cost always comes first. And the thing dearest to my heart, population health, comes third. And now you pointed out that maybe workforce should be front and center because we need such a resilient workforce, and the workforce is atrophied.
Can I speak to a minute about the costs issue? Because
Yeah.
I meant to say this and I didn't. Thank you. You know, when people talk about healthcare reform, a lot of times it like morphs into payment reform. And I've worked in payment reform for a number of years. You know, I worked at the Department of Vermont Health Access, leading their payment reform unit. You know, I've worked for, you know, everything from a health insurer, Blue Cross Blue Shield, to the Green Mountain Care Board, you know, but that is a means to an end. And I want to emphasize a means to an end, not the means to an end. The reason that we talk about reforming how we pay for healthcare is not, you know, to cut services, cut costs. Yeah, we do want healthcare to be affordable because that's a fundamental aspect of access, but really it's about changing the way that we deliver care. And there are a lot of other supports. You know, we have learned, we have tried, you know, not just us, but nationally, oh, if we change the way that we pay for healthcare, things will just magically change. And that's not true. There are other supports that are needed if we really want to improve the way that care and services are delivered. And again, I'll start ticking off a few. The work that you're doing, how can we, in a system particularly like Vermont's, where we have, we don't have a ton of vertical or horizontal integration. We have different organizations providing care and services. We tend not to be a hyper competitive state, so people work within their health service area and they collaborate. But it's still really hard to get multiple organizations working together on behalf of people who need care. So, you know, that type of coordination of care for people with complex needs. You know, it may sound boring, but it's really important. How do we use, collect, and analyze data so that we actually can tell how well we're doing? How can we support people in accessing care? And that's where equity comes in. So payment reform is but one element of overall healthcare reform. So I thank you for that reminder.
No problem. Let me let Allison ask the next question.
Trying to make you visible to the people.
I think the blur back.
Yeah. How about
Yeah.
the blur foreground? Let's do that.
It will be a blur.
Okay. Yeah. All right. Well, after I ask my question, I'll blur you both.
Okay.
And so, hey, in terms of when you're thinking about and listening to all of these conversations, in what ways can we build equity in the changes that are underway? Or that are in the changes that are possible? How can we build equity?
So I think we need to first think about what equity is when we're talking and define health equity. There's a lot of definitions floating around, but the basic one is for people to have a fair and just opportunity to attain their best level of health. And the key word there is their best level. not yours or mine or anyone else's. It really is the individual. And the piece that we don't talk about a lot, which comes into play, is looking at what underlies health equity, which are social determinants of health. And also a new idea called the political determinants of health, where we start looking at what are the processes that underlie policy and how we get here. So when you put those together and you start thinking about what's going on the ground level, part of what happens is people feel disenfranchised. And if we're trying to create equity in a system that doesn't have a lot, we really, really want to start thinking about what is the person experience and put that at the heart. And I'll give you an example that just happened to me. I'm not going to name the specialty because Vermont's a small state, but I had a specialist appointment and I walked in there with a chronic health condition. And I have a file about this thick coming from another state. And I walked in there knowing I went on all the releases and everything. And the doctor looked at me and said, well, I'm having a hard time believing what you're saying. Nice phrasing. And I don't want to rely on anything. So we're going to start from scratch. I left there in tears. It took me 15 years to get a diagnosis. And I went back to my primary, who apologized to me, said, we will send you to another person. So I'm going to be going out of state to find another specialist. So that's where health equity is not working because people's voices aren't being heard. But I think one of the steps that we've taken in talking is about peers and having that support, because I think that's an important piece, both for mental health and physical health. Part of what we really need to think about when we're talking about integrating health and parity, there's more than payment parity or treatment parity. There's also, this is the concept that gets pushed a lot, but we haven't really talked a lot, which is, when you have physical health, you have well visits. You should be having the same type of thing for mental health. That's parity when we're really starting to really look at health as health as health. And you said a really interesting word, Dr. Levine, that's my purview, which is resilient, which is actually one of my least favorite words. Because if you look at the history of resilience, it came from back in the 60s and 70s when it started coming in to talking about the equity conversations. And there was a lot of pushback because at the time, the word that people were using was transformation and transformative and adaptive and really looking at what's going on. And that scared people. And they went to resilient and used the term bounce back because it keeps the status quo in place. So how do we transform systems, I think, is part of health equity and part of what we're actually looking at when we're talking about pushing it in. So hopefully that answered your question. It was a little roundabout, but.
It does. And I like your note about resiliency because I do think when I think of it a little unfitting with some of, what Vermont's culture, this rugged individualism. And it's like, individually, I either am resilient or not. And therefore I have the skill of bouncing back or not. And as if we all have an equal opportunity to have that level of resiliency. And actually, due to all the things you just talked about, we don't.
No, and and when we're thinking about equity, it's not just color. It can be mental health. It can be body size. It can be a host of factors and a lot of intersections, which is what makes it so complex. But I think the first step is really giving people voice. Just like from the feminist movement, the personal is political. Well, so is healthcare. And it's highly personal. And it's a place where many of us feel very powerless.
Yeah. So I'm hoping both of you can talk a little bit about this fitting of our integration conversation into healthcare reform. And so my question is, what do you envision healthcare reform will mean for the integration of care? And are there unintended consequences, good or bad, that we should keep an eye on as the system moves to include more mental health services in healthcare settings?
Sure. So one of the things that we hear from people delivering healthcare and people receiving healthcare is that they would like flexibility in how care is delivered and how they receive care. They'd like predictability in payment for sure, but also, in what to expect when someone, goes to receive healthcare. And so healthcare reform, definitely some of the things we've tried to achieve are allowing people receiving care and people delivering care to determine how best to do that. When you're in a fee for service payment system, it's like you have to deliver this care to get this payment. If you can set up a system that's more flexible than that, then it allows some of that decision making to occur. One of the things that we did back in 2015 or so was we really worked hard in this state on and it's a terrible name, but I'll say it anyway, on the Integrated Communities Care Management Learning Collaborative. And I'm smiling at Mary Kate because she actually evaluated this effort. But what we were trying to do was set up, design a model for people with complex to really make that more integrated, smoother, less fragmented. And some of the key principles that we focused on in that model, and when I was looking at the whole health model that Kathy had sent some information, I thought, oh my gosh, this sounds a lot like this. First and foremost, what are the person's goals who's receiving care? Not what is the, health system's goals, what are the clinician's goals for that person? Healthcare. It can be about housing. It can be about food security. It can be about finances, legal issues, and it can be about healthcare. But that was sort of a basic tenet of that model, was the person decides what their goals are. We don't decide that for them. And then similarly, when you're dealing with multiple organizations, and maybe lots of care coordinators, is there someone that the person would select as their, what we call a lead care coordinator? Is there a person who's a trusted person that they would like to really work with, and then have that person help coordinate the other care and services and folks? A care team, who's going to be on their care team, not who we think should be on their care team. Should they have a family member? Should they have a peer on their care team? Should they have different providers? So how can we do that team-based care that the whole health model talks about? And then how can that team, including the person, work together to achieve those goals that are really important to them? And so we really worked hard. We worked with some national experts who, had been sort of groundbreakers in this type of work, did a lot lot of training. A lot of that has lived on. I was just in St. Johnsbury last week and they were talking about how they took that opportunity and how they've really, continued to, when new people, new providers come into the system, continue to really train them in that model. Lung Care adopted that model as part of their care management, care coordination work. And so, but there is so much still to do there. This is so complicated. And, it's sort of like entropy, like the natural thing is to just go work in our silos and it really takes a lot of constant effort to keep that type of integration going. And it's something that actually we're looking at again and really trying to see if we can keep those efforts going.
So,
Okay, oh, go ahead.
good. So one of the things that I was thinking about was unintended consequences. And that's really where health equity hits. In report after report produced by nonprofits or the state or anyone, I constantly see this population was too small to report on. We don't have data. There's an art collection, sort of a mixed media thing done by a data scientist, and it's a file cabinet that has files in it that you can go through it. And it's called the missing data set. And what it really is are like areas where you would love to have data and no one's ever collected it, or people have decided it's too much trouble to collect, which is how it feels. And I think that's, again, one of the unintended consequences we can have with integration is those of us who belong to groups that are too small to measure are going to get lost. When you see statements, and I've seen them like, well, we tried to contact people, but we couldn't, so we're not going to count them. Or, things like the population is so small that their rates don't really matter because they don't affect. Well, I think every individual matters. And that's one of my worries with integration is that's going to happen further. Another worry is what measures are we going to use? Because are they normed to that population if we're using quantitative? Are they going to work to get what we want? And the third arm is training and getting people comfortable with asking questions. To this day, so I was at the doctor. Looking at it and I look at race and it says unknown. No one has ever asked me about race in that practice at all. And last time I filled out my initial patient, I identified because I think it's important. If I don't do that, I'm not going to be counted. So we've got a ways to go. And these are some of the consequences that are currently happening that I'd love to see us really make recommendations about. And just some of the things we've put into place, I'm worried that we're just going to get further lost.
I think some of you know that I've done a bit of work in the past on quality measurement and identification of quality measures. And we cannot use small numbers as an excuse to not look at things. We simply can't. There are ways to do that. Looking at larger years, looking at, there are ways to bringing multiple payers together. We tend to measure for Medicare, for Medicaid, and for commercial, but there are ways to measure what's important. And not use that excuse of we don't have enough numbers. And then, I would just add another unintended consequence, going back to the whole health model. Be vigilant and relentless about making sure that the person's voice and their goals and their, what they are trying to achieve in their lives is front and center. And that, there's again, a tendency to sort of substitute a clinician's, thoughts, because we think we know people. But we really have to work hard to keep.
There's that, and I think too, for many of us, even those of us who are educated in this, you go to the doctor and you just shut up. Because you're scared, you're nervous, you think something is wrong, you think people are gonna judge you. So there's this piece of people education and teaching people that's okay to advocate for yourself, that it's okay to say, my main concern is housing. And when you think, and they're like, what does that have to do with housing? You're thinking, well, this person has diabetes, they're living in a hotel, they're eating out of a microwave. How are they supposed to be eating food that will help them manage their diabetes? So it does connect, and that's the piece we really start pushing on, or how do we change those underlying systems?
So picking up on the theme you both just put on the table, and knowing equity is such an important principle for this group, can you help us understand a little bit about how healthcare reform can help us build a more equitable system?
Yeah, I mean, I think we need to ensure that we have equity built into, not just as sort of a side activity, but that we really look at healthcare equity as central to any models that we put into place. I mean, that's the simplest way that I can explain it. I think we have a long way to go. I think because we really have to start to address the root causes of inequity. And that can be current systems that are in place that hinder access to care, that result in poorer outcomes, but it's also historic and systemic injustice that are really part of our world. And so I think we have to listen to the advisory commission, the governor's advisory commission. I think we'll have opportunities. The federal government, equity, like you said, is a word that's used a lot. But the federal government is making it clear that in future models, they want to see equity plans as central to healthcare reform. And so we have a lot of work to do in the state. We have a lot of work to do in this country, but we have an opportunity to really come together and design models and systems that speak to the current issues regarding equity and that speak to those historic and systemic issues as well.
And for me, would I love to just burn down the system and start over? Absolutely. Is that going to happen? No. So what I keep telling people when we're looking at health equity issues is the only way to eat a mountain is a bite at a time. So find your bite. So find those little pieces that we can really yank on, whether that's incentivizing, collecting correct data. People should be doing, they're not. So for every file, you get penalized or you get incentivized. Doing true qualitative measures too with underrepresented populations and asking them what they want and need. Starting to look at things that are respectful of diversity, whether it's acupuncture, Chinese medicine, naturopathy, some of the stuff we have, but some of it's not. And those are the things we need to start looking at because that's what people are thinking of as health. So I think we just need to look at what are the pieces that we can get immediately and what are the ones that are a little bit of a reach, but are within, if we do is we'll put a framework, oh, we've done this, now we can just move on. This is one of those things that has to be recursive, where we're constantly going back. And at the same time, we're working on the larger systems and the social determinants of health and the political determinants of health, and how do we start moving those pieces?
I was thinking the same thing when preparing for this about the quality. We need to hear people's stories. We need to, it can't just be quantitative data is helpful and it tells us how we're doing, but what also tells us how we're doing is that, qualitative information, talking to people and seeing what their experiences are.
Well, and if we're trying to break down the structures, part of structural racism is worship of number. And an absolute truth, because there is no absolute truth. What is true for me may not be true for you. So.
I think a few steps back, and I've heard from both of you when you were talking about the individual's expression of what their goals are, why they're there, what they might be reluctant to say, and tying it in with equity. I thought I heard a pretty sound endorsement of the concept of peer support in healthcare. Do you want to either affirm or not what I just said, as well as elaborate on it?
Yeah, and I think particularly in the area of mental health and substance use disorder, that ability to have peer support, somebody who actually has, nobody has the same lived experience, but who has, a similar lived experience. I think that's essential. And to the, again, I'll go back to care team, to the extent that a person wishes to have a peer as part of their care team, that should absolutely be honored. We need different modes of peer support. And I'll use, I'll provide some personal experience. I have loved ones many loved ones actually who've struggled with substance use disorder and mental health. And, what works for one of them, a 12-step program, it doesn't, work for another. Another family member needs more one-on-one, is more reserved. And, I know that we're working to have peer support in emergency departments. We have the turning point centers, for example, and, having different ways of accessing that peer support is, in my experience, essential. Because not everyone's going to respond the same way but I have seen phenomenal responses in my family to peer support. In some ways, more effective even than what has been good clinical care as well.
But Jay is going to have a lot to add, but if I could just interject one thing first. While you have the podium, so to speak, you made a good case for the fact that equity is maybe not job one, but it's certainly high number job for healthcare reform in the future. There's parity as well, and that issue of reimbursement for things like on not just the drawing board, but in our future.
I think we do have to look at ways to provide financing for peer support, for community health workers, for sort of different, different ways of delivering care. I'll look to Ann here, but we were both around back in the day when Vermont passed the mental health and substance use disorder parity legislation. We were pretty cutting edge then. I mean, we were leaders. It took the federal government a number of years to actually catch up. I remember being, and again, having family members that have dealt with substance use disorder. I remember being shocked and thrilled when Vermont passed that legislation and included substance. I thought, this is never going to happen. There's too much stigma, and when you were in the legislature. Yeah. No, you were. Okay. So, well, you were about to be in the legislature. And I remember when we added substance use disorder to the parity legislation, I thought, oh man, that is really something. And then Ann and I were on a work group together to ensure, and I'm looking to Sebastian and Anna, I think your name is, yeah, to try to ensure that parity insurance, health insurance parity was actually implemented as intended. And that was some work. Yeah. And I think it's still ongoing work to make sure that there aren't barriers set up. But, when I think about parity, I also think about disparity. What are those avoidable differences that we are seeing in our healthcare system in terms of access to care and in terms of outcomes, that, are caused again by, not by, the person, but in fact by either current issues or, historical issues, biases. And so I think that, yes, certainly, parity and financing for the full continuum of services for the full continuum of people who work with folks with these complex needs, but then also how can we solve for disparity?
Julia, thanks for holding your thoughts. Still happening.
So first thing for yes, I'm absolutely, and I've always been in support of peers. But we also need to include peers with physical health issues or chronic health issues, because yes, if we're looking at both, someone will come in with a chronic health issue and they've just received diagnosis and they don't know anyone with this. And having a peer who may at least have familiarity with dealing with a chronic issue is really important. So having people who have a variety of experiences. The second thing is we need to not medicalize peers, because that's one of my big fears is suddenly they're going to be wearing scrubs and they're going to be another medical person who's there. And we're going to lose the benefit. Yeah. But, I've seen it in other places and that's what I'm I'm worried about that. When we're talking about parity, one of the things that I really believe is we need to stop measuring, especially when it comes to cost, but also service, in terms of the education of the provider. We need to start measuring based on the intensity of the service provided. So, for example, if you think of someone who gets a BFA or an MFA, the MFA is a terminal degree, Master of Fine Arts. I know it's off, but I'm just saying. So for mental health counselors, for a lot of them, the terminal degree is a master's in mental health counseling. That doesn't mean they are any less important or less deserving than a physician, but they get measured differently because numbers of years of education. But they're just specialized. They're just specialized in a very specific area. And I think of people who are gonna be these peers and who currently do direct service and are paid the least and do the hardest work. And the work that is so necessary and where we're lacking, and we need to start looking at, if we're thinking about equity, how are we paying people? What are we how are we doing their hours? You know, we need to get creative and start thinking outside the box and say, 36 hours a week is full time. We're gonna pay you a living wage. We're gonna ask you to work 3 12-hour shifts and give you 4 days a week off so that we can schedule, you know, just anything outside the box, because we know how hard this work is. And we know how important it is to have people who are talented and experienced stay in the field. And I'm sorry, no one is gonna stay in the field for $15 an hour.
I know we're closing in on our time, and I'm sure everybody will at some point like to stand up and move their bodies, speaking of health. I did want to give you a chance, Pat, when we talked with Ina in November, when she was here, she mentioned that 2025 is a significant point. And so I think from your perspective, I'd love to know, what do you think this group should be aware of about that date and where we're going?
Well, the date has changed. No, I think, what Ina must have been referencing was that, so I think you all at least have heard the words Vermont's, all payer accountable care organization model. That is our current model with the federal government that allows Medicare to pay for healthcare differently in Vermont. So they're basically paying like a, you know, population-based payment that, affords some of that flexibility that the feds haven't been so, Medicare hasn't been so hot on the predictability side, but at least on the flexibility side, they've, paid for healthcare differently. So that model, we negotiated it and signed it in 2016. Medicaid, started, a new model in 2017, and then Medicare and commercial in 2018. It was supposed to be a 5-year model. It was supposed to end in 2022. And as we all know, some things happened in 2020 that made it really important not to disrupt the healthcare system. So we got 2 years of extension from the federal government, 2023 and 2024, and this is all calendar year. So the federal government was supposed to come out with a new model. They don't want to do a Vermont specific one or a Maryland specific one or a Pennsylvania. They want to do a multi-state model now. And so they were planning to come out with a model that we could look at and decide whether we wanted to apply, and they could decide if they wanted us to start in 2025. And in the last month or so, maybe we learned that that's not going to be ready for 2025, that it's now going to be 2026 before that model is ready. They just announced it last I can't. I'm gonna try, but don't hold me to this. It's something like states advancing all payer health equity approaches and development. I think that's like did I get it right? Oh my God. I'm gonna have to like practice it over and over again, because it's like the acronym's great, but the words just don't roll off the tongue. So that model is planned for now 2026. That means, what do we do for 2025? Do we try to do another extension? They're not going to create a new model for us. Do we go back to fee for service for Medicare? Don't really want to do that. So we're negotiating with the federal government right now on what to do for 2025. But let's talk about ahead for a minute, because there's some really key principles there about how to pay for healthcare, but I think more importantly about how to design a model. Paying for healthcare, there's a focus on what's called hospital global budgets. I'm not going to get into details, but it's again that sort of flexible, you give a hospital their budget. You want to monitor how they use it, but it gives them more flexibility. They want to hold us to what are called total cost of care targets. This is about affordability, but there's some other things in the model that are really intriguing. One is, can we increase support for primary care? Another is, how do we address mental health and substance use disorder needs and services? Another is, how do we address health equity? And then another is, how do we address social determinants of health? So there's some really, they want to see, and they want to support states in this, but they really want to see states tackle these things head on in the next model. So that not a lot of details yet, still pretty general. We'll get way more details in early December, we think, and that's when an application period will open up and states can decide whether to apply or not. We have really pressed hard with the feds I shouldn't call them that, with our partners. And we have pressed very hard to really, Vermont has done some significant innovation in these areas. I think of the Blueprint for Health expansion, to try and integrate mental health and substance use disorder care into primary care, and then also other health care. I don't like to call it physical and mental health. It's like other health care into mental health, like into, certified community mental health clinics and, or other, designated mental health agencies. So we've done some work, and we've really pressed hard with CMS to try and hold the gain and support the work that we've done. And I think they've started to hear us on that, so that we're not backsliding. So.
Kathy, we're gonna ask one more question.
Okay.
Because we started a little late, and then I want to let the group just have a chance to ask a question or two.
Great.
So my question, I'll try to make it focused and quick. And it is a little population health centric, that other part of the triangle, the AAA or the quadrangle of the quadruple A. But, moving from the practice level to the population level, what will healthcare reform mean in the public health world and are the equity on the population level?
So I'm going to be really short, but I think the dream, sort of the aspiration for healthcare reform, is that if we can, do better on access to care, addressing the needs of the individual, that it will then allow us to devote more resources to those upstream needs that really speak to care system. It's not inexpensive, but it's fairly lean when you look at the rest of the country. And in the same way that we don't want to assume that just if you change payment, everything's magically going to change, I think we also have to really keep an eye on, if you change payment and care delivery, will it free up resources for public health? Because it might not. And I think we have to be prepared to invest in public health if those savings aren't immediately realized. Some of this stuff takes a long time to come to fruition.
So I personally think public health is one of the hopes for me when it comes to health equity, because there's a lot more hidden power than people realize in public health. And I think if the Department of Health, which I've seen, 'cause I've worked with so many of different arms since I've started, really start centering health equity, especially looking at some of the processes, you as a department actually have the power to make some significant changes in how we do things. You know, one of the strengths as well as the weaknesses of Vermont is we're small. Okay, and the strength is that a change can have immediate effect. For example, grant making processes. You know, stop making people write grants. Let them do a video application, let them do an interview, let them do something that works for who they are instead of rewarding them for how well do you write or do you have a grant writer. So there's a lot of different ways for us to start looking at where public health can actually start modeling this, but also I think start looking at their own processes to say, okay, where are we going to do it? Because that's half the battle, is having the willingness to question yourself really harshly, because it's hard. And we don't always like to look at ourselves under a microscope.
Thank you. Did the discussion stimulate any questions from?
Hi, I'm Leslie. Again, not so much a question, but a comment. I would really encourage that we all retire the use of the word peer. I think that it's peer specialists that provide peer support, and that is the language that we should use. It is a discipline, and that's what many of us have been pushing for a long time. And that goes with the language of the state certifications being developed. So we really encourage, we don't use the word peers. We, as a group of people, we don't really want to be referred to that way. We are peer specialists.
Thank you.
Thank you.
And that's sort of akin to the substance use world.
That's where there's the lack of parity.
But, you know, common term is peer recovery coach.
It's recovery coaches is the certification.
And it has a certification behind
Yeah.
it and a certificate, the whole work. So whatever we
And I
call
don't
it,
call
we
it
should have.
here. I'm not
No,
sure
no,
why
but-
we're not.
That's what do all peers in one way.
Yeah.
That doesn't mean we're taking on this
Right.
role.
Exactly.
Yeah.
And the other is
So I agree with you.
It's-
Whatever word we choose,
our
we should
recovery
choose the word
stories.
that actually dovetails with the
Yes.
job description. So
So our work that we do that's so magnificent and specific is that we share our recovery stories. It's not that we're like sharing our sickness stories per se. So I think that's important, and I do plan on going to the work group session, but I just think these things are really important. When you speak of parity, I have to speak to the fact that there isn't parity for mental health care specialists that there is for substance abuse recovery coaches. We don't work in the ED, we don't work in the hospital, we don't work really hardly anywhere in the state of Vermont.
Thank you.
thank you.
This is Sebastian, and during the presentation, I was thinking a lot about how we talk about parity, because I think from the private payer standpoint, the commercial insurers tend to think about parity in terms of, okay, how do we map mental health and substance use disorder services onto med-surg services? And one of the things we talk about here a lot is mental health care is healthcare. And when we're talking about whatever med-surg service you can think of, we don't think about that in terms of like, oh, is there a analogous mental health service on the other side? I know that it's important to at once talk about parity, but I feel like the goal should be to move away from parity and just think about it in terms of, like, we discussed mental health care is healthcare. Like, if it's healthcare, there's no reason why we should have to say that, well, mental health peers are like substance use recovery coaches are like whatever other peer supports there are in the med surg world. It's all healthcare.
The issue,
We agree.
yes, there's parts of that I really agree with. The issue comes in with, really honestly, this intersection of business into healthcare and monetizing based on education or perceived worth. Because no matter what we seem to do, business really has a specific model of how to pay, but also how to regard. You know, if you are, all apologies, Dr. Levine, physician, you are all knowing in some ways versus you're just a mental health counselor and we're going to tell you that you can have 10 visits because we know you can solve that problem in 10 visits, which isn't always true. So I think, again, we have to it's the equity issue of getting into this underlying causes and thoughts of how do we think of people? I think what you're proposing is the great white hope that's sitting up here. We're just down here. And until we do the underlying work of looking at the structural racism and pieces that are built into our systems and the issues with classism and discrimination against people who may have a mental health challenge, people who are of a different color, people who come from a different country. All these pieces are playing in, and until we figure those pieces out, they're going to keep affecting what we're trying to do.
Yeah, I think one of the things Allison said at the beginning, one of our tasks is recommendations back in our report on how do we address what barriers there still are for full implementation of as not between mental health and physical health, but mental health being a part of healthcare, of all of healthcare. What I'm wondering is what thoughts from each of your perspectives, what kind of recommendations would you make to us about changes either in public policy or legislation that might be needed or would help further that as part of our recommendation?
I mean, I think continued support for making health equity and addressing disparities in health central to, not as an add-on, but really central to healthcare reform and to pretty much everything that we do that's health related. I mean, I guess I don't think it's going to just happen unless we make it happen. It has to be really, really intentional. So I guess that would be my biggest recommendation.
And mine is there are 2 tools right now. There is the racial equity impact tool that Susanna Davis created. There's also a racial impact equity tool that the Social Equity Caucus, it's a little shorter and more pointed, created. And I personally think it's already every policy and thing is supposed to go through these. I think the legislature really needs to look at saying, have we done these tools and looked at both the intended, because it makes it with the intended and unintended.
In other words, including mental health, bias against mental health as part of a tool that's also looking at
That's
How
in
is
there.
there implicit
Yeah.
that was in the.
It's actually in there in a way because the way the tool, even though it says race, it really asks you, are there groups that may be affected unintentionally? Or what policy have you thought of all of these groups and what this policy would do? So rather than saying, I want you to do a specific policy, I want you to do the tool on every policy. Because then you're gonna be asking yourselves the questions.
And, you made me think of something, which is that it's, in a way, there's sort of, can be a circular aspect to this. People who experience injustice and disparities, that is a contributor to mental health conditions as well as I mean, it's circular.
No, and I can tell you, I sat in that office with that white doctor going, yeah, here we go again.
Yeah, yeah.
Because I'm just like, there's more than enough in data backing up that I'm telling you the truth. So, with just it does, and one thing builds on the other, so it's important.
One final question?
I do occupational medicine. And I think one of the things in hearing this too is, and to sort of build on yours, it's circular. Within healthcare, there's a huge burden of mental health conditions and burnout. And also non-male healthcare providers experience a lot of discrimination and bias. And I think having that awareness in this work is really important. Healthcare systems and medical systems have a huge number of people out on medical leave because of diagnosis is related to the workplace. And I think in doing this work, we need to protect and improve the services we're giving to others and for ourselves and perspectives.
That's a really, essential point. When we think about sustainability of our healthcare system, that, first and foremost has to be that fourth aim in the triple aim. And, it sort of started out, and can I say, I don't know if it was happier times, but, that fourth aim came about sort of pre-pandemic, workforce shortages, aging populations. And so it was, joy of work, improve the experience, work life of healthcare providers. It feels like more of a crisis at this point, in terms of not only will we have enough folks to provide care and services. And I'm including community-based organizations here too. This is not just physicians and other healthcare providers, but it's across the board, and maybe even more so when we talk about peer specialists. So it feels like more of a crisis at this point. So thank you for that.
Let's give a great round of applause to the. This is the perfect sort of topic for our final day, as well as segue to the next part of the plans, which Kathy will help us understand. And I guarantee he will provide us with some stretch time.
Yes, definitely. Thank you. And thank you both, Pat and Dan. It's really great. So we are a little behind, not in nobody's fault here. We had a lot of technical difficulties. Just so everyone knows, bathrooms are around this corner. There are 2 down here, and there are also 2 directly upstairs above those bathrooms. Let's take 10 minutes. So if we come back here at 10:30, and then we're going to break into are into 4 breakout groups and cycle through those so we can get some feedback, beginning or continual feedback on interim recs. So thank you very much. There's still coffee and tea and I think bagels and some sweets over there. So help yourself, please.
The folks online, Kathy.